congenital heart defect. First, heart sound. We have been discussing about this, and it is due to closure of the atrioventricular valve, meaning the valve in between the atrium and the ventricle. So to the right, you have the tricuspid valve. To the left, you have the mitral valve. This is longer than the second heart sound, about 0.14 seconds. Of course, it can be heard by your stethoscope, and it would sound like love. The second heart sound is diastolic in timing. This is now because of closure of the semilunar valves. Again, it should have been named properly as ventricular arterial valve, meaning the valve in between the ventricles and the great vessels, the pulmonary artery and the aorta. So to the right, you have the pulmonic valve, and then to the left, you have the aortic valve. It is high pitch and compared to the first heart sound, again heard by the stethoscope, and it would sound like dub. So lahat kayo should be able to hear this because ito yung basic na sound. So it would appear as can you hear that? Narinig niyo? Narinig niyo?
Yes po, Doc.
Yes po.
Yes po, Doc.
Basic siya, lub-dub, lub-dub, lub-dub. So yung first heart sound, hindi natin mahiwalay yung tricuspid and pulmonic valve masyado kasi halos sabay sila eh. Even if, for example, you put the stethoscope on the tricuspid valve area, although you will say this is a tricuspid valve, pero halos mahirap silang ihiwalay. Unlike the second heart sound, we can differentiate the two, meaning the aortic valve sound versus the pulmonic valve sound, depending on the location, because there is a splitting. There is that normal splitting of the aortic valve closure and pulmonic valve closure. But as a first year, hindi nyo papag-aaralan yung masyado yung splitting. You will learn more about listening for the first and second heart sound. So this is important. You should be able to understand what's the cause of the closure of the first heart sound, its timing. It should be during systole, and the closure of the second heart sound is during the diastole, and what's the cause of the second heart sound. So as a first year, dapat alam niyo yun. Okay, kahit saan nyo naman ilagay yung stethoscope nyo, maririnig nyo yung lub-dub, lub-dub. But the strength of the sound, syempre mas magiging malakas marinig yung second heart sound if it's at the base of the heart, and you can hear better the first heart sound if you put the stethoscope on the apex of the heart. Okay, third heart sound and fourth heart sound are a bit pathologic. Pwedeng normal kung talagang bata, athletic, but most of the time, these third and fourth heart sound are abnormal. So third heart sound and fourth heart sound are during diastole. There are phases in the diastole. Alam natin yon, yung apat na phase, isovolumic relaxation time. We have the rapid feeling, diastasis, and atrial systole. So the third heart sound is heard during rapid feeling. Dapat kasi during rapid feeling, when the mitral valve opens, right lang sa left lang tayo, when the mitral valve opens, dapat yung flow ng blood from left atrium to left ventricle, kahit ang daming blood nun, it should not be turbulent. So it should be like laminar. So dapat walang sound. However, in certain cases, like in heart failure, because of too much amount of volume of blood, and then it causes turbulence because of higher pressures. So this inrushing blood from the atria, causing ventricles to vibrate, is heard as a third heart sound. So this is heard on the middle third of the diastole or during the rapid feeling. Okay, so the fourth heart sound naman is due to stronger contraction of the atrium during systole. Dapat kasi the atrial systole should not be heard, but in heart failure, for example, because there are some blood retained during the last phase of diastole, and that's atrial systole. So because of this increased volume and increased pressure, the atrium contracts stronger than expected, and you hear a fourth heart sound. So fourth heart sound is during atrial systole. That's the last phase of, of the diastole. Is that clear? Did you hear that? All right. So, kahit cardiologist ako, I can identify a third heart sound. But a fourth heart sound, to be honest, hindi ko rin masyado ma-appreciate. So, but this third and fourth heart sound on examinations will come out as abnormal sounds, and third heart sound is during rapid filling, and fourth heart sound is during atrial systole. So it would appear as the third heart sound should appear yung fourth heart sound is just before S1. Kasi di ba, atrial systole after that will be the closure of the mitral and tricuspid valve. So while the third heart sound will be after the S2 kasi mas malapit siya doon. So yun yung mahirap sa kanila i-identify. So it's more of practice. This is how a fourth heart sound should. While a third heart sound should so ganun siya. We call the third heart sound as S3 gallop. Parang nagmamarcha daw na kabayo. Okay. So hindi rin ako masyadong strict among students to identify S3 and S4. This is just important during examination that you should know that S3 is because of rumblings or turbulence during rapid filling of the diastolic phase, while S4 is because of atrial systole, stronger contraction of the atrium during atrial systole. So yun lang. And both of these are not normal sounds. S3 and S4 are abnormal sounds. S1 and S2 are normal, but S3 and S4 are abnormal. Okay? Yes. So, kailangan nyo itong memorize because I think there will be 2 questions from this slide alone. So, this is basic kasi. The position of the aortic valve, you should not be able to forget about this position. So aortic valve is best heard at the second right intercostal space along the parasternal border, while the pulmonic valve is on the second left intercostal space along the left parasternal line. So there is an angula Louis on the chest area. So immediately below that, that's the second intercostal space. So the right side will be the aortic valve position, and on the left side will be the pulmonic valve position. So you count up to the fifth intercostal space. After the dito sa third or fourth, but most of the time it's fourth. But sometimes I hear that on the third intercostal space. So we call it civisternal junction on the left side. That will be the position of the tricuspid valve. While the mitral valve is at the apex, that's the fifth left intercostal space along the mid-clavicular line. So kailangan nyo siyang i-memorize because, for example, you are asked, a systolic murmur heard at the fifth left intercostal space along the mid-clavicular line. So you know it's a mitral valve, and what will be the cause of the murmur if it's a systolic murmur during contraction of the LV. So mitral valve, it can either be a mitral regurgitation or a mitral stenosis. So if you say a systolic murmur, then you know that it will be a mitral regurgitation. And if it's a diastolic murmur at the fifth left intercostal space along mid-clavicular line, then it's mitral stenosis. So sa aortic valve area, pwedeng during systole or diastole. So it can either be aortic valve stenosis or aortic regurgitation. Same with pulmonic valve area, it can be during systole or diastole. So it can either be pulmonic valve stenosis or regurgitation. Sa tricuspid valve area then, during systole or diastole, then you will know it's either mitral regurgitation or, tricuspid regurgitation or tricuspid stenosis. So based on the location of the murmur, where these murmur are best heard, and identifying its phase, either during systole or diastole, it will help you what kind of pathology in the valve. Clear? So ulit lang, aortic valve is at the second right intercostal space along the right parasternal line, while the pulmonic valve is on the second left intercostal space along the left parasternal line. Mitral valve is at the fifth left intercostal space along the mid-clavicular line, and tricuspid valve is at the left side of the zipisternal junction, or fourth or fifth intercostal space, left left parasternal border. Pwede din siyang ganun. But for your exam, it will be at the left side of the zipisternal junction. Is this clear?
No.
Kayang-kaya yan. Mga bata pa kayo, kayang ma-memorize yan. So, my mnemonic is always pray to Mary if you are Catholic. So, always pray to Mary. So, aortic valve, pulmonic valve, tricuspid valve, then mitral valve. If you nakukuha niyo ba yun? Parang always pray to Mary. Ganun ako mag-mnemonic until now. Anyway. So, valvular lesions in rheumatic heart disease, kasi this is the most common cause of valve problems, rheumatic heart disease. This is caused by rheumatic fever from streptococcal infection followed by an autoimmune response. So it will cause scarring of the valve that can either result into stenosis or incompetence of the valve, which is regurgitation. So pag rheumatic heart disease, hindi lang stenosis. There are rheumatic heart diseases involving the mitral valve that is predominantly of a mitral regurgitation rather than an stenosis. So pwede siya. Either stenosis, meaning narrowing of the valve, meaning during opening of the mitral valve, hindi nag-o-open ng maganda. And regurgitation, during closure of the mitral valve, hindi nagko-coaptate ng maganda, and it would result to regurgitation. The most common valve involved in rheumatic heart disease is still mitral valve. And this is followed by aortic valve, then followed by tricuspid valve, and yung least is the pulmonic valve. But all the valves can still be affected in rheumatic heart disease, and most of the time, dalawang valve ang affected, hindi lang isa. So for example, there can be involvement of the aortic valve and the mitral valve. Okay? So depending on the prominent valve pathology, yun yung i-comment mo as the main source of heart failure. So I have patients na merong severe mitral regurgitation, mild mitral stenosis, and moderate aortic regurgitation. So that's rheumatic heart disease predominantly of a mitral regurgitation. Okay? So common yung dalawang valve, hindi yung isa lang valve. So most of the time we have patients na dalawang valve ang involved. So, murmur. Pag sinabi na nating murmur, pag sa cardiology kasi when we say sound, this is normal. But when we say murmur, abnormal na siya, meaning there is turbulent flow of blood through a damaged valve that produces audible murmur or thrills. Yung thrill is something that we can palpate. Murmur is something that we can hear on auscultation. So these are abnormal turbulence of flow. So there are two murmurs, systolic murmur or diastolic murmur. So kailangan nyo siyang ma-memorize. Siguro as a first year, medyo mahirap lang siya. Even my residents, minsan naguguluhan. I was also a resident and a first year student before, nagkakamali din ako. So systolic murmur. When we say systolic murmur, the murmur is heard during systole. And this can be caused by tricuspid or mitral regurgitation. Pag sa semilunar valves, it can be caused by pulmonic and aortic stenosis. So if it's a systolic murmur based on the graph, the loudest would be aortic stenosis. Did you get that? Wait lang ha, may tumatawag. Okay. Systolic murmur. So, when the tricuspid valve, it's a regurgitation. Kasi pag contract ng right ventricle, dapat yung tricuspid valve should be closed properly, avoiding leakage of blood. But if this tricuspid valve is incompetent, meaning hindi nag-coaptate ng maayos, it will cause blood to regurgitate into the right atrium. Same with mitral regurgitation. So during left ventricular contraction, the papillary muscles and the chordae should hold the mitral valve to prevent it to prevent bulging towards the left atrium, and also to help in the coaptation of the mitral valve. So if there are problems, the papillary muscles or chordae tendon causing prolapse of the mitral valve, or if there's problem with the mitral valve na hindi sila nag-close ng maayos, so it will cause mitral regurgitation. So during systole, the aortic valve should open widely, but if it does not open properly, then it will cause stenosis, and it will cause regurgitation. It will cause turbulence of flow during systole across the aortic valve. Yun yung maririnig mong murmur. And the same way with a pulmonic valve stenosis. So memorize. Systolic murmur, it's tricuspid and mitral regurgitation, pulmonic and aortic stenosis. So depending on the location, let's say you hear a systolic murmur on the second intercostal space, right parasternal border, then you will say it's aortic stenosis. Parang ganun siya. Okay? So diastolic murmur naman, if it's on the mitral and tricuspid position, that's stenosis. But if that's heard during in the pulmonic and aortic valve position, then that is due to regurgitation. So mitral stenosis causes the weakest murmur among all the diastolic murmurs. So, for example, you hear a diastolic murmur at the fifth intercostal space left mid-clavicular line, then you will say this is probably due to mitral stenosis. That's how you are going to be asked during exam. Okay? Did you understand that?
Yes, Doc.
All right.
Can you repeat, Doc? Hello, Doc? Medyo choppy, sorry.
Hala, narinig niyo ba yun?
Hakon part, Doc. Sorry, medyo choppy.
So, systolic murmur, you hear the murmur during the systolic phase, meaning contraction of both the right and the left ventricle. So try to imagine nagko-contract the right ventricle. So if there is pulmonic valve stenosis, you will hear a turbulence. So on the pulmonic valve area, so that's pulmonic valve stenosis. If it's on the tricuspid valve, the cause of the murmur is because hindi nag-coaptate yung tricuspid valve, meaning incompetent yung tricuspid valve. That's why there's leaking of blood into the right atrium. So that's tricuspid regurgitation. On the left side, the left ventricle is contracting. So if you hear a murmur on the aortic valve position, that is because of an stenosis. Kasi dapat during systole, the aortic valve should open widely. But if the aortic valve does not open properly, then there will be turbulence of flow during systole across the aortic valve. And so that is due to aortic stenosis. On the mitral valve position, if the mitral valve kasi dapat during systole, when the left ventricle is contracting, the mitral valve should coaptate properly. Dapat naka-close siya. Dapat the papillary muscles as well as the chordae tendineae should hold the mitral valve para hindi siya mag-bulge towards the left atrium. Kasi kung there is problem to the chordae tendineae, it would result to prolapse of the mitral valve, and this will cause leaking of blood into the left atrium during systole na dapat wala, and that's because of the murmur that you will hear will be because of a mitral valve regurgitation. So based on the location of the valve and its timing, either systole or diastole, then you will know what kind of valve pathology. For example, let me just give you an example. There is a systolic rumbling murmur heard at the second intercostal space, right parasternal border. What is the valve pathology?
Aortic.
Aortic.
Aortic what?
Stenosis.
Right. So, ganun kayo mag-isip. First, i-memorize nyo yung location ng valve. Aortic valve is at the second intercostal space, right parasternal border. Pulmonic valve is in the second intercostal space, left parasternal border. Tricuspid valve is in the fourth or fifth intercostal space, or in the citisternal junction, that's on the left parasternal border, while the mitral valve is in the fifth intercostal space, but on the mid-clavicular line, that's basically at the apex of the left ventricle. Okay, so by memorizing the location of the valve, then kung saan mo best naririnig yung murmur, you have to time it, either systole or diastole, and then it will help you what kind of pathology. So let's give another example. You hear a systolic murmur at the fifth intercostal space, left mid-clavicular line. Anong cause ng valve pathology? Systolic murmur?
Mitral
Mitral what?
Regurgitation pala.
Will be mitral regurgitation. So, hindi pwedeng mitral lang kasi sa choices merong mitral regurgitation and mitral stenosis. So kung piliin mo yung mitral stenosis, mali yon because mitral stenosis is diastolic phase. You were correct with the valve position, but you were wrong on the kind of pathology. Kasi sa timing dapat magkakaiba sila, either regurgitation or stenosis. Did you understand?
Yes,
Yes,
Correct.
Doc.
Yes po.
So, systolic murmur of aortic stenosis, again, the blood ejected from the left ventricle through a narrowed opening of the aortic valve. The aortic valve opening kasi should be 2 centimeters square, pataas, so more than 2 cm squared. But if it's less than 2 centimeters squared, there is stenosis. So 1.5 to 2 is mild, 1 to 1.5 is moderate, and less than 1 centimeter square is severe aortic stenosis. You don't need to know the centimeter square. Just know that if there is narrowing of the opening of the aortic valve, then it would result into a murmur, and that's because of aortic stenosis. The resistance to ejection produces very high ventricular pressure without corresponding increase in aortic pressure, and murmur occurs during systole. It is described as harsh in sound. Actually, this is the loudest murmur among all the systolic murmur, kaya hindi pwedeng magpamali kayo dito. The murmur is transmitted throughout the superior thoracic aorta and even into the large arteries of the neck. This is very important clinically because yung aortic stenosis na murmur is best heard at the second intercostal space, right parasternal border, and it can radiate to the carotids as well as to the apex of the heart, meaning at the fifth intercostal space, left mid-clavicular line. Pag sinabi natin radiation, the sound is of smaller quality, lower quality as compared to where the source of the murmur. So It is louder on the right intercostal space, a second intercostal space, right parasternal border, and there is still radiation on the apex. So baka sabihin mo na yung murmur at the apex is because of a mitral regurgitation, because mitral regurgitation is also systolic murmur at the fifth intercostal space, left parasternal border. So paano mo siya ma-differentiate if it's an MR or aortic stenosis? Ma-differentiate mo siya, one, this is louder on the aortic valve position, and second, it radiates to the carotid arteries. Very important clinically. So without 2D echo, for example, you are just going to diagnose, you hear a very loud murmur, best heard at the base, and it radiates to the apex, but it also radiates to the carotid arteries. That's aortic stenosis. Did you get that? Hello?
Doc.
Doc.
Okay. So let's na-appreciate nyo ba? Mahirap, no? At your level, siguro mahirap. But through experience, you will be able to distinguish the two by memorizing the position and knowing the phase or the cycle of the cardiac cycle kung saan mas naririnig yung murmur, then you will be able to identify the kind of valve pathology. Okay. Mitral regurgitation is also a systolic murmur, and in mitral regurgitation, blood flows backward through the mitral valve into the left atrium during the systole. It will cause a high frequency blowing, swishing sound occurring during systole. Okay. And the sound of mitral regurgitation is transmitted to the chest wall, mainly through the left ventricle to the apex of the heart. So the mitral regurgitation is best heard at the fifth intercostal space, left mid-clavicular line, but it can radiate to the base and it can radiate to the back. So depending on its radiation, when we say radiation of the sound, meaning naririnig mo siya sa base, but mas lower na yung sound, hindi na siya mas louder, parang ganun. That's radiation. So you will know that it's a mitral regurgitation, not aortic stenosis, because there is no radiation to the neck. Hindi mo siya maririnig hindi mo maririnig yung murmur and the carotid artery. So we will say that this is mitral regurgitation. Did you get that?
Yes po, Doc.
Yes, Doc.
Okay, so let's try to So, merong swishing, alam yon. Kanina kasi parang bombo radyo. I don't know paano ba siya i-describe. At loud kanina. Ito naman, merong shh. Baga naihi nga, daraga. Swishing sound. Sorry. So, ganun siya. So, because these are both during systole, you can differentiate the two by its location. Again, you should memorize the location of the valve because kung saan mo mas narinig, louder, mas loudest yung murmur, on which position, then you will know it's either MR or aortic stenosis because both of these are during systole. Another differentiating factor is that aortic valve stenosis can radiate to the cardiac. Wait lang, may tumatawag. Ah, dumating yung package. Okay. Are there any questions so far between aortic stenosis and mitral regurgitation? Kasi parehas sila systole, madi-differentiate mo lang on the location. So far, okay? Okay tayo?
Yes po, Doc.
All right. So let's now go to diastolic murmur. Aortic regurgitation, no abnormal sound is heard during systolic kasi nga diastolic siya maririnig. So when the aortic valve closes, dapat walang magli-leak. So the aortic valve is closed during diastole. So blood flows backward from aorta into the left ventricle if the aortic valve is incompetent, meaning pag close niya may nakabarang calcification dyan, kaya hindi na masyadong maganda yung closure or butas yung aortic valve. Kaya kahit maganda yung coaptation pero butas naman yung aortic valve, then there will be leaking of blood into the LV during the diastole, and it will cause a blowing murmur of relatively high pitch with a swishing quality. So pag regurgitation, swishing talaga siya kasi blood na nagsisip pabalik, nagli-leak. And again, this is heard maximally over the left ventricle. So yung aortic valve position kasi natin is on the, di ba, right, second intercostal space, right parasternal border. So the aortic regurgitation can be a little bit heard on the pulmonic valve area. Kaya medyo magulo lang siya.
It's up sa diastolic, Doc.
Okay. So ulitin lang natin. Aortic regurgitation is because of incompetent na closure ng aortic valve. Kasi dapat the aortic valve during diastole should close properly. So if there is a calcification, obstructing, at kunwari merong malaking calcification at the tip of the aortic valve, kaya yung closure makakaabala yung calcification na yan. So there will be leaking of blood. Or merong butas sa aortic cusp. So it would cause leaking of blood even if the coaptation of the aortic valve is good. So this is leaking of blood from the aorta into the LV during diastole. So yeah, kaya siya diastolic murmur. Now, you have to listen to this at the aortic valve position that's on the second intercostal space, right parasternal border. However, because the aortic regurgitation is leaking, parang alam yun, kung makikita mo sa 2D echo, mahaba siya na flow nagli-leak siya pabalik. So the blood is directed towards the LV. Kaya minsan, or most of the time, the murmur is not heard at the second intercostal space, right parasternal border, but this is best heard on the pulmonic valve area, that second intercostal space, left parasternal border. Did you understand that? So, paano mo naman malalaman na this is aortic regurgitation because of its diastolic phase? Ngayon, mahihirapan ka kung ano siya, pulmonic valve stenosis. Nagets niyo ba? Kasi parehas sila, hindi pulmonic valve stenosis, pulmonic regurgitation. Kasi yung pulmonic regurgitation is also during diastole. So mahihirapan kang mag-differentiate between the two. And that's okay. So you will just say this is either aortic regurgitation or pulmonic valve regurgitation. But during exam, you will be asked if the murmur is at the second intercostal space, left right parasternal border, then that's aortic regurgitation, not pulmonic valve regurgitation. And if it's on the second intercostal space, left parasternal border, na diastolic murmur, that's pulmonic valve regurgitation, not aortic regurgitation. Did you get me?
Yes, Doc.
All right. So, ganito yung aortic regurgitation. Narinig niyo yon? Yung murmur?
Hindi po.
Parang wala. Wala daw.
Yung wala.
Ay, Sidor. Eto. Did you hear that?
Yes, Doc.
Yes po.
Yes, Doc.
Paano ba natin siya i-describe? Ang hirap po mag-describe ng murmur eh.
Terminator.
Baga ko na pahala kayo kung paano niyo siya i-describe. So, tinuturo sa amin to based on location, based on the character of the murmur, but the art of identifying the murmur on physical examination is already decreasing. Parang yung mga students natin ngayon hindi na ganun kagaling. So, even consultants na internists, hindi na rin ganun kagaling. Alam na nilang merong murmur, but hindi na nila kayang identify what kind of murmur. Pero kung sa level nyo ngayon, parang madali lang naman, no? Because you just have to identify if it's systolic or diastolic, and then the location, then matutulungan ka na. Actually, ganun lang naman siya kasimple. But you need experience in this para maging magaling kang mag-identify. Okay. Mitral stenosis is of significance because ang dami-daming patients na merong mitral stenosis. Blood passes with difficulty through the stenosed mitral valve from left atrium into the left ventricle. Because pressure in left atrium rarely reaches 30 millimeters mercury, the abnormal sounds in MS are usually weak and a very low frequency. Kaya ang hirap-hirap mag-diagnose ng MS. No murmur may be heard during the first third of diastole. That's okay. After partial sealing, the ventricle has stretched enough for blood to reverberate and a low rumbling murmur begins. So MS, the mitral stenosis murmur is heard at the fifth intercostal space left mid-clavicular line during the diastole. So napaka-low lang na sound na minsan hindi ko rin na-detect, but you just go clinically. Okay? So ganito yung sound. Actually, ganun siya. Pero ito kasi magnified eh. Parang pina-increase. In clinical, sobrang hina lang niya. Parang ewan lang. Parang lang siyang vibration during the diastole at the fifth intercostal space. Para siyang merong, paano ko ba i-describe? Yung grating sound pag yung plastic inaano mo. Anong term yan? Basta ginaganon mo yung plastic, ganun lang siya kung marinig mo yung MS. But its location on examination is on the fifth intercostal space, left mid-clavicular line, and diastolic space. Okay, so aortic stenosis can either be compensated or decompensated kasi both, actually all valves can result into heart failure, So if it's aortic stenosis na compensated, meaning na nakapag siya, there will be a decreased stroke volume or cardiac output because di ba narrowed yung opening, mahihirapan yung paglabas ng dugo, and that's why the stroke volume is decreased. However, there will be left ventricular hypertrophy, kakapal yung thickness ng LV, and hindi natin na-discuss to, but this is because of Laplace law. If there is an increased pressure, in order to decrease the tension, the wall tension, dapat yung thickness lumaki. Anyway, yun yung explanation ng LV hypertrophy. And then there will be an elevated left ventricular pressure because there will be damming of blood in the LV, and increase in volume means an increase in pressure. However, the aortic pressure on the aortic side is mababa kasi nga decreased yung lumabas na dugo. Okay? And there will be an increased blood volume meaning blood volume in the LV, in the LA, in the lungs, causing congestion. And some patients will have polycythemia kasi nga yung aortic stenosis, habang dumadaan yung dugo across the aortic valve, these red blood cells are destroyed and can result to anemia. And then the net effect is to increase production of RBC, kaya nakakaroon ng polycythemia or increased hematocrit. When we say decompensated, that is meaning to say, hindi nag-adjust, alam mo yun, hindi nakapag-adjust yung puso. There will be an increased severity of all itong compensated stage. And then there will be dilatation of LV. Makapal siya plus dilated, and the left atrium is also dilated. There will be congestion, and it would also result in ischemia of the left ventricle because any dilatation of the LV will cause ischemia. Question so far? Mahirap? Okay. So, mitral stenosis can either be compensated also or decompensated. So, compensated, there will be low arterial pressure because the blood in the left. Can you hear me?
Choppy po, Doc.
Hello?
Choppy po.
Choppy.
Hello? Hello? Oh, I am sorry.
Medyo
Narinig
choppy
niyo
po,
pa
Doc.
yung aortic stenosis? Dito? Choppy to? Aortic stenosis?
Okay lang, Doc. Okay po yung
Yes po, Doc.
My
Dyan po. Choppy.
Okay. So mitral valve can either be compensated or decompensated. Pag sinabi natin in the heart to somehow adjust. Okay, so ang mangyayari lang sa compensated stage, because of mitral stenosis, there will be low arterial pressure. Bakit mababa? Kasi nga hindi lumalabas, hindi makapasok yung blood across the mitral valve, kaya decrease yung blood in the LV. So when the LV contracts during systole, konti lang din yung lalabas across the aortic valve. And that's why there is a low arterial pressure. There will be a reduced
Doc, choppy po.
Doc, choppy po.
volume.
Doc.
Kasi nga, konti yung
Choppy.
Mag-imagine kayo ng pathology, yung effect sa heart, kailangan yung imaginein kung nasaan yung pathology. So in mitral stenosis, the mitral valve is not opening properly. So what will happen to the blood? There will be damming of blood in the LA. So the left atrium will have an increased volume and pressure. And this will be reflected as an increased pressure on the right ventricle. Okay? Because of that, there will be left atrial and right ventricular hypertrophy, dilated and hypertrophied. But because the blood is not able to properly go into the LV, so the LV will be smaller, the blood volume in the LV will be smaller, and that's why the stroke volume is decreased, the cardiac output is decreased, and so there is a low arterial pressure. So mapapansin nyo yung patients with mitral stenosis, they have relatively low BP. Minsan yung mga BP nila 90-50, 100/60, ganun yung mga BP nila, and mapapayak sila. Okay? And on 2D echo or an X-ray, the LV is not dilated. Kasi nga, the problem is in the mitral valve na stenotic, hindi makaflow yung blood from left atrium to left ventricle. So ganun kayo mag-imagine. So when we say decompensated, all the mechanisms to adjust, kasi if the left atrium dilates, ma-accommodate niyo yung increased volume and pressure. So somehow, hindi masyadong magkocongest. But if maximize na yung pag-dilate ng left atrium, then the pressure is reflected back into the lungs, causing pulmonary edema, and then the patient will have, kasi severely dilated in left atrium, there will be scarring of the left atrial wall, there will be ischemia of the left atrial wall. It would result into atrial fibrillation. And if the pressure is too high, it is reflected in the RV. The pressure in the RV is increased, the RV dilates, the RV is hypertrophied. It would result to RV ischemia kasi yung demand is increased in the right ventricle. But all of this will result into reduced arterial pressure. Naintindihan nyo?
Yes po, Doc.
Okay, laban lang. Laban. So aortic regurgitation, this time naman, there is a leaking blood from the aorta into the left ventricle. So imagine niyo, sobrang dami ng dugo in the left ventricle. So ang mangyayari yan is there will be an increase in volume and pressure similar to aortic stenosis. Now the difference is that ang mangyayari sa aortic regurgitation, it's more of dilatation agad-agad. Unlike in aortic stenosis, mauuna muna yung hypertrophy, and then eventually, pag mag-fail na, pag maging decompensated na, then that's the time that the LV will dilate. But in aortic regurgitation, this is more of LV dilatation rather than hypertrophy. So, mapapansin niyo yan as you go into third-year medicine or in internal medicine or in cardiology, na pag stenotic, it's more of hypertrophy of the chamber of the heart. But if it's because of regurgitation, the net effect is more of dilatation. Kasi dilatation is because of increase in volume and hypertrophy is because of stenosis. That's in Laplace law. Hindi natin diniscuss yung Laplace law. Anyway, kasi mas pang higher education na siya. Pang Ohm's law pa lang daw kayo at pa Sells law. Okay? So an MR is because again of a reflux of blood into the left atrium during systole, and the changes are similar to MS with one exemption that the left ventricle is enlarged. So in MS, hindi affected si LV, meaning walang masyadong problem sa LV. Actually, lumiliit lang siya kasi nga konti yung blood na nag-flow from left atrium to LV. But in MR, because there is leaking of blood, ang mangyayari yan, the blood leaks into the left atrium, but when the valve opens, yung daming of blood, yung blood that is the increased blood volume in the left atrium will all be reflected or released or drained into the LV during diastole. And that's why the LV will dilate. Increase in volume will cause an increased dilatation of the LV. So just to help you analyze, if it is stenosis, it is more of hypertrophy of the chamber. If it's regurgitation, it will cause more of dilatation of the chamber. Did you get that?
Yes.
Again,
So let's go to congenital heart disease. And I have this in your book, there are only 4 naman na masyadong inexplain. So left to right shunt, meaning PDA. There is also atrial septal defect, ventricular septal defect, and 1 na right to left shunt, yung tetralogy of Fallot. So 4 lang ang lalabas sa exam. Okay, let's start with PDA. This is ductus arteriosus that fails to close at birth. So dapat itong connection between the aorta and the main pulmonary artery should close. It should close. Kasi pagkaanak mo, pag-breathe mo, when the lungs is already functioning, tataas kasi yung pressure, this PD, patent ductus will have to close. I mean, the ductus arteriosus has to close. Okay. But if mag-persist yung ductus arteriosus, then that's a problem. So ang mangyayari, mas mataas ang pressure in the aorta than in the main pulmonary artery. So there will be a left to right shunt. Blood will flow from the aorta into the main pulmonary artery. Now, even during the diastole, the pressure in the aorta is still higher than the main pulmonary artery. So it allows flow from the aorta into the main pulmonary artery during systole and diastole. Did you understand that? Nagets niyo ba yun?
Yes po.
yes po, Doc.
Hello?
Yes po, Doc.
Narinig niyo ako?
Yes po, Doc.
Okay. So let's try to imagine your internet connection is unstable. So So blood will flow from the aorta into the main pulmonary artery. So there will be more blood in the lungs, and there will be more blood in the left atrium. There will be more blood in the
Hello?
Hindi,
po,
Doc.
Doc.
Okay. So let's try to dissect anong nangyayari sa PDA. So this ductus arteriosus dapat siya to close upon birth. But if it fails to close, it would result to a patent ductus arteriosus. So ang nangyayari is the aorta has a higher pressure. Aorta has higher pressure than the main pulmonary artery. So there will be a flow, a left to right shunt from the aorta into the main pulmonary artery. So even during the diastole, since the pressure in the aorta is higher than the main pulmonary artery, so there will be a flow during systole and diastole. And this is basically the reason why you hear a machinery-like murmur. It will be a continuous murmur even during systole and diastole. But try to think that the flow of blood will be going into the main pulmonary artery and go to the lungs. So there will be flooding of blood in the lungs. There will be more blood in the left atrium, more blood in the left ventricle, and then back into the aorta. So the chambers that will dilate are the left atrium and the left ventricle, not affected yung right atrium and right ventricle. Did you understand that? So, if for example, chronic na, matagal na, and there will be pulmonary congestion, there will be changes in pulmonary pressure, tumaas ang pulmonary pressure. Because of that, that's the time that there will be RV hypertrophy, if there will be pulmonary hypertension. But suffice to say, the first or the chambers that are dilated in PDA are the left atrium and the left ventricle, and supposed to be the RA and the RV are not affected. But if chronically there will be increased pulmonary pressure because of increased flow in the lungs, and then there will be changes, concentric remodeling of the arterioles or arteries in the lungs, it would result into an increase in pulmonary pressure, and that's the time that there will be RV hypertrophy. Okay tayo? That's PDA. So this is supposed to be the murmur in PDA. So dapat hindi itong mid-diastolic, no? Mistake, sorry. It should be like continuous flow. Even during systole and diastole, there should be flow. More flow. Hello? Okay na yung sound. Hindi ko lang na-share ko. Did you hear that?
Yes,
Yes,
po.
Doc.
Yes, Doc.
During systole and diastole, may naririnig pa rin kayo. That's, we call it a continuous murmur or machinery murmur. Wait lang, nakakahiya. Physiology behind PDA. The chambers that will dilate are the left atrium and the left ventricle. And then there is a continuous murmur because there is a connection between the aorta and the main pulmonary artery. And because the pressure in the aorta is higher than the main pulmonary artery, it will cause a left to right shunt. And because the pressure of the aorta is always higher as compared to the main pulmonary artery, both in systole and diastole, that's why there is a continuous murmur. There will be RV hypertrophy only when there is pulmonary hypertension. But if there is no pulmonary hypertension, then the RV and the right atrium are normal in size. Are we good? So, if you are diagnosed, ang madali lang sa PDA is if you memorize a continuous murmur or machinery murmur, kahit anong pagsasabihin pa yung case, a 32-year-old male, whatever, blah, 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 and then there is a continuous murmur or machinery murmur. Agad-agad, anong diagnosis?
PDA.
Arteriosis.
Correct. Next. Tama na yan. So, let's go to interventricular septal defect. So, ang mangyayari nito is that there is a butas that connects between LV and RV. So, because the LV has a higher pressure as compared to RV, then the flow of blood will be from LV into right ventricle. Now, take note that the flow will be during systole. Tama? Kasi pag contract ni RV and LV, mas tataas ang pressure ni LV compared to RV. So there will be flow of blood from LV into the RV. And because the RV is also contracting, the RV will just be a conduit. Blood will not stay in the RV. It will just be a conduit because blood will be directed immediately into the main pulmonary artery. So there is more blood in the lungs, more blood in the left atrium, more blood in the LV. So the chambers that will dilate are the LA and the LV. Did you get that? Hello? Okay, so we will hear the murmur as a systolic murmur that is best heard at the third or fourth intercostal space left mid-clavicular line. Left parasternal border. Doon mo maririnig yung interventricular septal defect. So, if you come to try to think of it, yung murmur ng VSD is similar to a murmur of a tricuspid valve. Tama? Kasi nandun din yung tricuspid valve, yung fourth intercostal space, left parasternal border. Nandun din yung septal defect, or minsan lang mas mataas si septal defect, but almost same location sa tricuspid valve location. So, yun yung differential diagnosis mo. If you hear a systolic murmur in the fourth intercostal space or fifth intercostal space or third intercostal space, left parasternal border, it can either be a VSD or a tricuspid regurgitation. So, to the echo will help you differentiate the two. But at least on clinical grounds, you know that the systolic murmur heard is either because of interventricular septal defect or because of the tricuspid regurgitation. Again, a VSD is a left to right shunt, and that's because the LV has a higher pressure as compared to the RV, and the flow is during systole, kasi that's the time that the pressure are higher. I mean, the pressure in the LV is higher than the RV, and so ang mangyayari yan is the flow will be directed into the RV, but since the RV is also contracting, the RV will just be a conduit of blood. It will not stay in the RV, so the RV will not dilate, and blood is directed into the main pulmonary artery, into the lungs. There will be increased blood in the left atrium and the LV, and that's the reason why the LA and the LV dilate. So chronically, because of damming of blood, increased flow of blood in the lungs, if there is chronic pulmonary congestion, there will be concentric remodeling of the arteries, resulting into increased pulmonary pressure. Once there is pulmonary hypertension, that's the time that there will be RV hypertrophy. Did you understand? Did you get that? Hello? Naririnig pa ba ako?
Yes, Doc.
Yes po, Doc.
Anyway, ganun lang yung murmur niya. Pero actually, sa location din, yung ganung murmur, pwede din siyang MS, no? Well, so it's just the location that will help you. Kung saan mo maririnig yung murmur, you will have an inclination, or at least will guide you to what is the pathology based on the location, either also at the face, either systole or diastole. Next, interatrial septal defect. Now, there is a hole in between the left atrium and the right aorta. Most common hole is at the foramen ovale. So, magkaiba ang patent foramen ovale lang, and then this patent foramen ovale is already large. then it becomes an interatrial septal defect. Hello?
Yes po, Doc.
Can you hear me?
Yes, Doc.
Hear you po.
Hello? Okay. So at the foramen ovale, there is like a large hole. Then it would result into a left to right shunt because the LA has a higher pressure than the RA. So the RA will have more blood, the RV will have more blood. And that's the reason why the chambers that will dilate are the right atrium and the right ventricle. Did you understand? And the murmur that you will hear, you cannot hear a sound during the flow of blood from the left atrium to the right atrium. What you will hear is the increased flow of blood from the RV across the main pulmonary across the pulmonic valve. So when the RV contracts, nagigets niyo ba ako? Are you with me? When the right ventricle contracts, there is an increased amount of blood that is delivered into the main pulmonary artery across the pulmonic valve. Yan yung maririnig yung murmur, not the blood that passes through the left atrium to the right atrium across the large patent foramen ovale. Kasi yung flow na yan is, ano lang, mahina lang na flow kasi mababa lang yung pressure difference is not so high, and so the flow is, it will not cause too much rumbling murmur. And so, hindi mo maririnig yung murmur ng flow across the atrial septal defect. What the murmur that you will hear during systole is the increased flow of blood across the pulmonic valve. Did you understand? Hello? Kailangan maintindihan nyo yon kasi pag tinatanong kayo, sasabihin nyo, also what is the murmur that you will hear? Your answer would be based on at the time, isipin mo, kasi there is a left to right shunt across the interatrial septum, then that's the cause of the murmur, the flow of blood across the interatrial septum. Pero this is, yung mahina lang yung flow dyan hindi siya malakas. And so hindi mo maririnig yung murmur. Yung maririnig mong murmur is the increased flow across the pulmonic valve. I hope this is clear. So the chambers that will dilate are the RA and the RV. And then there will be an elevated volume and output in the right ventricle. And so the RV can also be hypertrophied, and later the RV will be, there will be failure. And then the oxygenated blood in the right atrium and right ventricle. So itong tinatawag na left to right shunt. So far, yung tatlo is a left to right shunt, meaning the oxygenated blood is, there's a mixing of oxygenated blood and deoxygenated blood. So kaya siya left to right shunt. Nakukuha nyo, so PDA, ventricular septal defect, and atrial septal defect, because the pressure in the left is higher, and so the shunt will be, the flow of blood will be from oxygenated blood on the left going into the right. So there is a left to right shunt. Kaya magiging acyanotic yung pasyente kasi nga mixing of oxygenated and deoxygenated blood naman to. Okay? I hope that is clear. Let us go to tetralogy of Fallot. Among all the right to left shunt, ito yung pinaka-common. So, yung mnemonic namin sa mga right to left shunt starts with letter T. Lahat sila starts with letter T. So, right to left shunt. But anyway, so the components of a tetralogy of Fallot is there is pulmonary valve stenosis. The valve is stenotic. There will be, since the valve is stenotic, little amount of blood will go to the lungs. Mabubuhay lang yung pasyente because of an interventricular septal defect. So, because of this interventricular septal defect, mabubuhay yung pasyente because blood will somehow be directed into the aorta. So, there is now overriding of aorta. When we say overriding of aorta, the aorta kasi dapat is facing the left ventricle. But if it's now facing towards the right ventricle, in between the RV and the LV, that's overriding of aorta. And then, because of this, there will be RV hypertrophy, not left ventricular hypertrophy. So, That's the 4 components of tetralogy of Fallot. Whatever happens, kailangan nyo itong memorize. Overriding of aorta, pulmonary stenosis, interventricular septal defect, and RV hypertrophy. Nakukuha nyo? Bakit nag-hypertrophy ang right ventricle? And that's because there is pulmonic valve stenosis. Hindi makaflow ang blood into the main pulmonary artery, and so it will hypertrophy. Kanina, according to Laplace law, because of an stenosis, because of an increased pressure across the pulmonic valve, in order to decrease the wall tension in the RV has to increase its thickness. That's Laplace law kasi. So anyway, hindi kasi natin yun na-discuss, but that's the reason why the RV hypertrophies because of pulmonic valve stenosis. Again, there is overriding aorta and there is an interventricular septal defect. So when you go to exam, an interventricular septal defect pwedeng palitan into an interatrial septal defect. A right ventricular hypertrophy pwedeng palitan into a left ventricular hypertrophy. A pulmonic valve stenosis pwedeng palitan into an aortic valve stenosis. So you have to memorize the 4 components of tetralogy. Kaya nga siya tinawag na tetralogy kaya 4 yung components niya. Hindi 3, hindi 2, hindi 1, kundi 4. Okay? Now, because there is a right to left shunt, meaning the blood from the right ventricle goes into the left ventricle, so ang nangyayari yan, hindi ka kasi magiging left to right shunt. The blood in the LV cannot go into the RV because close to pulmonic valve. So all of the blood will now be directed into the aorta. And that's why there is a right to left shunt. There will be mixing of blood. A deoxygenated blood in the RV will go into the aorta. So there is mixed blood of deoxygenated and oxygenated in the aorta. So nababawasan yung mixing in the aorta kasi may nakahalong deoxygenated. So somehow yung oxygenation mababa na in the aorta. So that's why there is cyanosis. Blue baby pagpaanak. Did you understand that? So the patient will die if it is uncorrected. Mamamatay sila eventually because of a low oxygen level in the arterial blood, in malnourished, hindi mag-grow na maganda yung baby, plus the heart failure because of RV failure, the patient will die eventually. Yay! Okay? Naintindihan nyo? Meron lang akong, before I open the floor for questions about this topic, may nag-text kasi parang naguguluhan daw sila about the Ohm's law and the Possel's law. So Ohm's law is it states that the flow is directly proportional to a change in pressure. So I'm just trying to explain to you na difference, not basically the pressure itself or the increased pressure. Naririnig niyo pa ba ako? Hello?
Yes, Doc.
So I give you an example of 2 vessels. The first vessel, the opening of the vessel, the pressure is 100 millimeters mercury. At the end of the vessel is 80 millimeters mercury. So 180, the pressure difference is 20. Okay? The other vessel, 50 millimeters mercury. At the end of the vessel, the pressure is 10 millimeters mercury. The pressure difference is 40 millimeters mercury. Which of the 2 do you think will have a better flow? Hello? Ano yon? The first vessel, the pressure at the beginning of the vessel is 100 millimeters mercury. At the end of the vessel is 80 millimeters mercury. So there is a pressure difference of only 20 millimeters mercury. The second vessel, the beginning of the vessel has a pressure of 50 millimeters mercury. At the end of the vessel, the pressure is 10 millimeters mercury. And so there is a pressure difference of 40 millimeters mercury. So if we compare the 2, mas mataas ang pressure in the first vessel, mas mababa ang pressure in the second vessel. But in terms of pressure difference, 20 millimeters mercury sa vessel A and 40 millimeters mercury sa vessel B. So which of the two vessels have a higher flow?
B.
Right to that. I hope naintindihan nyo yon. Because it's not on the pressure itself, but on the pressure difference that causes the flow. Ang blood kasi, or a volume of blood, or flow of fluid is from higher pressure to lower pressure. So the higher the difference between the two, the better the flow. The lower the difference between the two, the lower the flow, even if the pressure, actual pressure, is higher in vessel B, kasi 100 millimeters mercury and 80 millimeters mercury, as compared to 50 and 10 millimeters mercury, mas mataas yung pressure in vessel A. But because of the pressure difference, mas increase ang flow in vessel B. Did you understand?
Yes,
Hello?
Yes,
So a
Doc.
change, the higher the pressure difference, the better the flow. Now, this is inversely proportional to resistance. Because isipin nyo, kung maliit naman yung pinagdadaluyan ng dugo, because of a decrease in, if the resistance is increased, the flow of blood will also decrease. Did you understand? Kasi nga, na-obstruct yun eh. Na-obstruct siya. So, we can also use this in our cardiac physiology that itong formula na to is similar to a cardiac output that is equal to mean arterial pressure minus the RA pressure. That's the pressure difference. And this is inversely proportional to total peripheral resistance, meaning to say, if you increase the pressure difference between the mean arterial pressure and right atrial pressure, the cardiac output will increase. But if you increase the total peripheral resistance, the cardiac output will decrease. Kasi nga, you have decreased the vessel opening, the lumen of all the arterioles, for example, then there will be a decrease in diastolic return. So eventually the cardiac output will have to decrease. So if by mathematical derivation, you can also have this kind of formula that the change in pressure is equal to the flow times resistance. And this is similar to what we use, that blood pressure is equal to cardiac output times total peripheral resistance, meaning increasing cardiac output and increasing total peripheral resistance will increase the blood pressure. Another mathematical derivation, dito minsan nagugulo eh. So, right, it states that resistance is now equivalent to an increased pressure but decreased flow. So, if you increase resistance, it will increase the pressure. However, you decrease the flow. Kasi opposite sila. So, this is similar to saying that increasing the total peripheral resistance will somehow increase the arterial BP, but eventually will decrease the cardiac output. Okay? In Possel's law, it states that flow now, before kasi niyo maintindihan yung Possel's law, you have to understand that yung ginawang study ni Possel's law is in a tube, and ang ginamit niya is water or Newtonian particles, whatever, if you are very good in physics. I'm not very good in physics. So blood is non-Newtonian because hindi siya purely fluid. Plasma siya, alam niyo, red blood cells. There are a lot of sodium, albumin. Iba yung component niya, hindi lang siya fluid lang eh. But anyway, based on Possel's law, pwede naman natin siyang magamit that it is directly proportional to a change in pressure as well as the radius by the fourth power. Meaning to say, if you increase the vessel diameter, you will improve the flow. If you decrease the vessel diameter, you will impede flow. Okay? And kinuha lang niya yung other factors that affect the flow of blood, like the viscosity of blood. Increasing the viscosity, let's say, if it's more viscous, then the flow is decreased. And the length of the vessel, the longer the vessel, the slower the flow. So based on mathematical derivation, they were able to get resistance based on Possel's law. Now, my mistake is, on the previous slide, nandun pa rin si pressure, pero by cancellation, mathematical cancellation, dapat wala na si pressure. So there are 3 factors only that affect resistance, and you need to memorize this because this will come out in exam. One is viscosity. The higher the viscosity, the higher the resistance. Ketchup versus tubig, alin yung mas mataas ang resistance? Ketchup, di ba? Next, length of the vessel. The longer the vessel, the higher the resistance. The shorter the vessel, then the lower the resistance. And this is inversely proportional to radius. And among all the factors, viscosity, length, radius, it is radius that is that has a greater effect to resistance because it is to the fourth power. And a little increase will greatly or maximally affect resistance. Okay, so this is the reason, the explanation behind stenosis of a vessel, a mitral stenosis or coronary artery stenosis, cerebral artery stenosis. It will greatly affect the flow. It will increase resistance and therefore affect the flow of blood. So yun yung understanding na makukuha nyo. So if we talk about resistance, there are three factors. Directly proportional to viscosity, directly proportional to length, and inversely proportional to radius to the fourth power. So among the three factors that affect resistance, it is radius that is the most important because it is to the fourth power. So if you are asked, what will happen to the pressure if the resistance is increased?